Hi everyone, my name is Dr. Kari DiVito and I am a board certified cardiovascular and pulmonary clinical specialist. And I was inspired to become one just prior to the onset of that COVID-19 pandemic. As I was becoming more and more involved with our ECMO program, established in 2018 right here in Morgantown, West Virginia. Now, rehab services were always part of our ECMO care protocol, but prior to the pandemic, the use of ECMO wasn't in such high demand as it would later become. So we got really good at mobilizing and rehabilitating these individuals who needed ECMO support at that time because we found ourselves frequently at maximum capacity. Given that there's not an official guide for mobilizing the patient on ECMO, and we were having such great success during such a trying time in healthcare, I was eager to share with the rest of our rehab community just how we do it. And so I'm here to tell you a little more about our manuscript, Cannulate, Extubate, Ambulate, how the pandemic accelerated development and implementation of early mobility for patients requiring extracorporeal membrane oxygenation. Now, very early literature discussing involvement of the rehab team in care of the patient on ECMO said maybe this is too risky and we should wait. But more recent literature says yes, let's involve the rehab team, but it is going to take interdisciplinary teamwork to make that a success. So this manuscript will tell you about our 3-phase protocol for mobilizing and rehabilitating these patients, which goes along with our team motto, Cannulate, Extubate, Ambulate. During the pandemic, I was the only PT in this state seeing these patients who were COVID positive and in isolation, which meant I spent a lot of time donning and doffing PPE. So my day began with a conversation between myself, the patient's bedside nurse, and ECMO specialists. Our nurses and ECMO specialists use a 1-to-1 staffing ratio at our facility, meaning the patient has one nurse and one ECMO specialist assigned to them. Together, the three of us would determine the patient's appropriate phase of mobility, which can be found in Table 1. So we try to discover if the patient is medically unstable and maybe not appropriate for rehab efforts, or would they only tolerate low-level activity at this time? Or maybe they're awake and critically stable and ready to participate in that active rehab process. And so this was very important when we're trying to conserve as much PPE as possible, but we also want to intervene when the patient would receive the most benefit. And that also helped us to protect our staff from being inappropriately exposed. And acute care PTs can surely relate to how this conversation helps with patient prioritization. So once we determine which phase of mobility the patient is ready for, we gather the appropriate team members and assign everyone involved a role. This helps us keep our patient safe. We complete our rehab session, but the key has been to involve the ECMO team in mobility outside of when the rehab team is available. The PT and OT each provide recommendations to the staff for performance of future mobility and self-care tasks after the rehab session is completed based on how the patient performed that session. Now, there was much teaching to the other ECMO team members about lifting and movement, body mechanics, and use of lifting equipment to allow that to occur, but the results were evident that involving everyone in mobility is essential. None of our patients are excluded from our mobility protocol because being cannulated at all means that this patient has a meaningful chance of recovery. Even with more than half of our patient population during the pandemic having a femoral cannula, 51% were ambulatory while cannulated, and on average, they were ambulatory by ECMO day 9. We had the highest published ECMO survival rate of COVID-19 infected patients at 70% survival during 2020 and 2021. And 60% of those individuals were able to discharge directly home from the hospital, which is twice the international average reported by ELSO. We utilized the AMPAC 6 clicks to track changes in functional limitations. And while admitted to the ICU, where all team members are involved in the rehab process, there was a 43% improvement in function, with the average AMPAC score being 20 when the patient was transitioning to the step-down unit. Because of that 1-to-1 staffing ratio, nursing staff had actually documented more sessions of activity than us PTs or OTs were able to provide alone. So our interdisciplinary communication and collaboration greatly benefited these patients that we saw during the pandemic, and we are going to continue to cannulate, extubate, and ambulate for years to come because of these great successes that we saw.